Hi, everybody. I'm Erin Abramson. I am currently serving as the deputy in the policy unit of the COVID-19 response for CDC, and I would like to welcome you to today's CDC partner update call. This call serves as a way for us to share weekly updates on COVID-19, along with our latest resources and guidance, especially for the private sector and other partners. Today's call will focus on testing and contact tracing in non-healthcare workplace settings, but we will also cover more general updates and information. For the agenda today, we will hear from our COVID-19 response Chief Medical Officer on where we are with the response and about what everyone should know about protecting themselves and others. We'll then turn to our subject matter experts who will discuss CDC's latest interim guidance for contact tracing and testing in non-healthcare workplaces. Afterwards, our speakers will take questions from the audience. Please note, this call is not intended for media. Media can direct their questions to media@cdc.gov. This call will be recorded and later posted on the CDC COVID-19 website, as well as on YouTube. All past partner calls can be found there, so please take some time to review and share prior recordings. If this is your first webinar with us, these weekly calls occur every Monday at 3 p.m. Eastern Standard Time. Please see the link on the slide to subscribe to our mailing list to receive future CDC COVID-19 partner update webinar invitations. Note, there are multiple listservs that support this call. So if you have missed an invitation over the last few weeks, please click on the link in the chat box provided to ensure that you are on the listservs. I would like to remind all participants that the CDC website has the latest information, guidance, and communication resources. There are over 2,000 documents providing information and guidance for individuals, businesses, and the public on our website. In addition to the tools we'll highlight today, some resources posted within the last 2 weeks include our toolkit for businesses and workplaces, considerations for restaurants and bars, a toolkit for employees and worker safety, event planning and COVID-19 questions and answers, considerations for wearing cloth face coverings, and general business frequently asked questions. We also have a toolkit for the general public and a link to investigating and responding to COVID-19 cases in non-healthcare work settings. We want to thank those who sent questions in advance. We've already teed up a few of those questions and we'll be keeping an eye on the Q&A box. So please feel welcome to submit questions there as well. Note that we will not be viewing the chat box, so please utilize the full functionality of the Q&A box. We're very pleased to be joined today by 3 CDC experts. Dr. John Brooks, our Chief Medical Officer for the COVID-19 response, Sarah Luckhaupt, Chief Medical Officer, Worker Safety and Health Team on the COVID-19 response, and Dr. John Piacentino, our Associate Director for Science in the National Institute of Occupational Safety and Health, or NIOSH. For those of you logged into the webinar platform, there will be very few slides used today, so please don't be alarmed if they don't seem to be advancing. Additionally, a transcript will be provided along with this video when it is posted online to YouTube. I'd like to now turn it over to Dr. Brooks for some updates.
Thank you, Dr. Abramson. Hi, thank you, and welcome to everyone joining with us, the call with us today. It looks like there are over 750 of you. As Dr. Abramson mentioned, my name is John Brooks, and I'm the Chief Medical Officer for CDC's COVID-19 response. And today I want to provide just a brief update of the COVID response at CDC and some of the latest scientific developments and guidances we've put out. So let me start with the situational update. As some of you may be aware, globally, we've now crossed the 14 million line in terms of 14 million cases diagnosed worldwide with over 597 deaths since July 20th. Here in the US, there have been 3.6 million confirmed and probable cases reported to CDC, and tragically, almost 140,000 deaths. These represent 25% of all cases and deaths reported worldwide since the beginning of the pandemic, which is also more cases and deaths contributed by any other country. The United States nationally remains in the acceleration phase of the epidemic. The number of new diagnoses, unfortunately, is continuing to steadily rise throughout the country, and the country as a whole, as well as many states, are reporting new record daily case counts. We are also seeing an increase in deaths after a period of decline. The duration and severity of the current phase of the pandemic will vary by state. Achieving control will continue to depend on strong public health response, including increased access to testing and widespread adoption of non-pharmaceutical interventions that include social distancing, hand hygiene, face covering in public when you can't stay 6 feet away from others, covering your coughs and sneezes, and avoid touching your face. In addition to routine disinfection of high-touch surfaces, increasing ventilation, and of course, monitoring for illness in yourself and others. I'd encourage you, along with my colleagues, to view CDC's COVID View for a weekly summary and interpretation of key indicators that have been adapted to track the COVID-19 pandemic in the United States. It may seem hard to remember, but 7 months ago, no one knew anything about this disease. Since then, scientists around the world, including those at CDC, have been working tirelessly to learn more about the virus that causes COVID-19, how it affects us, and how to prevent its spread. Just this week, we've learned some interesting new things about COVID-19, and I'd like to share some of those with you now. First is a paper that was published in the Journal of the American Medical Association last week, looking at long-term sequelae or long-term side effects of COVID-19 illness. This paper reported on the condition of 143 COVID-19 survivors in Rome, Italy. Their average age was 56.5 years with a median hospital stay of about 13 days. Almost 3/4, about 74%, had evidence of pneumonia by X-ray, and only 7 of these patients were mechanically ventilated. So these are sort of typical of middle-aged patients who had a moderate illness, but really didn't require prolonged hospitalization and are sort of a lot like the people we see who get sick. 60 days after the onset of symptoms, so 60 days after they started to feel ill, these people were reassessed with a questionnaire to determine whether they still had symptoms. And this is what they found. Only 13% reported no longer experiencing any symptoms, 13%. 30% were still experiencing 1 to 2 symptoms, and over half, 55%, were experiencing 3 or more symptoms. And 44% expressed that they still had not returned to the quality of life they were enjoying before they became ill. And in terms of what symptoms were persistent, the most common ones were fatigue, shortness of breath, and pain. So this report is important because it shows us that many people recovering from COVID-19, if not most, have not returned back to their normal baseline of health 2 months after being infected. This is a serious illness and has still unknown long-term side effects. Staying home when you're sick is an important way for us to keep everyone healthy, together with the other actions I described before that include social distancing when you go out, frequent hand washing for more than 20 seconds, and using a hand sanitizer with at least 60% alcohol, and wearing a mask or face covering when you can't maintain social distance. Speaking of face masks, I also want to share some new information that is reassuring about the value of wearing cloth face coverings or other face coverings in public. Some of you may have seen a report from last week's CDC morbidity and mortality report published towards the end of the week, and that really provides new evidence supporting the use of cloth face coverings to prevent the spread of the virus that causes COVID-19. At a Salon A, an unnamed salon in Springfield, Missouri, 2 stylists with COVID-19 symptoms, in other words, who were infected and exhibiting symptoms, worked closely with 139 clients before these 2 stylists were diagnosed with COVID-19. And none of their clients developed COVID-19 symptoms. Both of the stylists and 98% of the interviewed clients followed posted company policy, as well as an ordinance from the city of Springfield requiring face coverings by employees and clients in businesses providing personal care services like a hair salon. The citywide ordinance reduced maximum building ordinance reduced maximum building waiting area seating to 25% of normal capacity, and also recommended the use of face coverings at indoor and outdoor public places where physical distancing was not possible. Both the company as well as the city's policy were important factors in preventing the spread of SARS-CoV-2 during these interventions between clients and stylists. And I remind you, these were hairstylists. These were close contact, and they were generally more than 15 minutes. These results support the use of face coverings in places open to the public, especially when, in the case of a hair salon, for instance, social distancing simply isn't possible, and that can help reduce the spread of SARS-CoV-2 virus. The results of this study suggest strongly that a policy mandating the use of face coverings helped prevent this transmission of SARS-CoV-2 during these close contact interactions between stylists and clients. Consistent and correct use of cloth face coverings when appropriate, at the right place and at the right time, is an important tool to minimize the spread of this virus from both symptomatic persons, but also those people who may be shedding the virus before they develop symptoms, or so-called pre-symptomatic persons, and the sizable fraction of people who will develop the infection but never have symptoms of illness, or who remain asymptomatic. CDC recommends workplaces put policies in place regarding the use of face coverings for employees and clients, in addition to daily monitoring of signs and symptoms from employees of illness, screening employees who arrive with or develop symptoms at work, and post messages to inform and educate employees and clients about COVID-19. Some information about some of our new guidances and resources, finally, I'd like to share with you. We have changed our guidance for isolation, for discontinuing isolation and precautions for adults with COVID-19. CDC, and I'd like you to pay attention, this is important, CDC now recommends using a symptom and time-based strategy, and no longer recommends using a test-based strategy to either end isolation or discontinue precautions, except in some very special circumstances. So for instance, if you think or you know you have COVID, then 10 days after, you may discontinue isolation or precautions 10 days after symptoms first appeared, and if there has been no fever without fever-reducing medication for at least 24 hours, and your symptoms are improving. They don't have to be gone, but we'd like to know you're on the mend. If you tested positive for COVID-19, but you never developed symptoms, then you can start counting those 10 days as of the date of the first positive test you received. Now, there are some people who may be very severely ill, and there is at least one source of information that suggests some of these people may need to isolate for up to 20 days. And for those kinds of people who have very severe illness, we recommend consulting with an infection control expert or an infectious disease expert as needed for that particular situation. I just want to point out that we are now recommending the symptom-based strategy apply to most people with COVID, but with one exception, and that is persons who have severely weak immune systems. When I say that, I'm not talking about people who are immunocompromised but doing well, for instance, someone who might have HIV with a suppressed viral load and a robust CD4 cell count, or a person who's recovered from breast cancer 5 years ago and may be taking tamoxifen but is really doing fine. We're talking about people who have very, very serious immunocompromise. For these people, we suggest they may need testing to understand if they've cleared the infection. And we strongly recommend that these people be managed in collaboration with an expert in infectious diseases. This is based more on theoretical concerns than observed concerns, but we think it's a reasonable concern to have. We know that with regard to other infections, other bacteria, and other viral infections that people with very severe immunocompromise have, they can continue to shed live virus or bacteria longer than other people can. We don't have enough data yet to know how long that might be in the case of COVID, but that's the one area where we're still going to recommend exercising some precaution. But for all other persons, a test-based strategy is no longer recommended except to discontinue isolation or precautions in the event you want to do it before you reach that 10-day point. So there may be some people who you really want to get them out of isolation for some reason before they complete their 10 days. And if you can get a negative test before then, they're probably good to go. So I finally want to mention, CDC has recently released what we call the Key Times video series. That's capital K, capital T, Key Times video series. These are available on our website at cdc.gov coronavirus. And these short videos share CDC guidance on when it's important to practice social distancing, wear a face covering, wash your hands, wear gloves, clean and disinfect your home, clean and sanitize toys in a child care program. So all of us are part of helping slow the spread of COVID in our communities, schools, and workplaces. And to talk a little bit more about that, I'd like to now hand over the presentation to my good friends and colleagues, Doctors Luckhaupt and Piacentino, to share guidances for workplaces. Sarah? And you might be on mute still, but we'll just hang a minute and see if we can get you on the line.
This is Erin. Let's see if we can get Dr. Luckhaupt.
Yeah, and while we're waiting, I can just say that, we recognize this is a big change in our isolation and precautions guidance, but I want to explain to people maybe for a moment another point about making this change. We know now that people who are infected with this virus, even after we can no longer find culture positive virus in their specimens, especially upper respiratory specimens, they keep shedding the RNA that's inside the virus, so this virus particle. The PCR test that we use for diagnosis and that some people are using as a test-based strategy, that test detects the presence of that RNA, that genetic material. And so the problem that we're getting into is that we now have very good evidence that the majority of people are no longer shedding live virus after around 10 days, maybe a few up to 20. But when you keep testing people, we know that people can produce a positive PCR test as long out as 12 weeks. So it's led to this situation where people who really don't pose a threat of infecting others continue to test positive and are kept in the hospital and occupying a bed that may be used for somebody else, or they can't get back to work. And we really need that to get the economy started again. Or it can lead to psychological burden for people who think that they're infectious to others because they keep getting this positive test when in fact it's not really representing infection. It's just showing that they're shedding RNA. We don't yet understand exactly why that's happening, and a lot of people are very interested in understanding it. This was a similar problem, for those of you who remember, that we faced with Zika in semen, that men continued to have positive semen. The test detected the presence of the RNA, but we now know that they really didn't have live virus in their semen after a short period of time following infection. So it's a similar phenomenon, and we're really looking forward to learning more about what that might represent. And we'll get back to you as soon as we know, or hopefully before somebody knows. Let me see if Dr. Luckhaupt is on the line.
Yeah, Dr. Luckhaupt is here now. Thank you so much. And we could probably keep Dr. Brooks on the line all afternoon and continue to learn from him, I'm sure. Let's see, Sarah, were you able to find your way back to us?
Hello, I think so. Do you hear me now?
Yeah, we do. Thank you.
Okay, great. I apologize for that delay, having some various technical issues today. So thank you, Dr. Brooks and Dr. Abramson. And as they said, my name is Dr. Sarah Luckhaupt, and I am currently serving as the Chief Medical Officer within the Worker Safety and Health Team for the CDC COVID-19 response. And today I'm pleased to share information on a very new resource that hasn't even been published online yet, but has just been finalized, titled Case Investigation and Contact Tracing in Non-Healthcare Workplaces, Information for Employers. So this resource includes information on what case investigation and contact tracing may entail, on the type of collaborations that may occur between health departments and non-healthcare workplaces when a COVID-19 case is identified that impacts a workplace, and the important role that employers may play in aiding the health department to further investigate and limit further spread of COVID-19 in the workplace. So health departments have the legal authority to conduct case investigation and contact tracing activities to slow the spread of infectious diseases in their communities, including COVID-19. So if a confirmed or probable case of COVID-19 is identified in a workplace, the health department may request assistance from the employer to identify contacts and prevent further spread of COVID-19 or the virus that causes it in the work environment. CDC encourages employers and health departments to collaborate when investigating workplace exposures. quick and coordinated actions could lower the need for more extreme mitigation strategies in the workplace, such as short-term business closures, to prevent the spread of this disease. Now, how much an individual employer may be involved in the official health department case investigation or contact tracing process will vary. It will depend on the authorities, responsibilities, and capacities of the local health department, federal, state, and local laws and regulations, and the level of interest and capacity of the employer to participate. So in some situations, health departments may choose not to engage with the employer, for example, if they do not need any assistance or information from the employer in order to identify and follow up with all workplace contacts, say in a very small business. In other cases, they may ask the employer for help in understanding the workplace and identifying exposures and contacts in the workplace. Or in some cases, the health department may actually execute an existing agreement with the employer and rely on the employer to carry out the workplace side of the investigation and contact tracing of employees. When preparing to collaborate with the health department, employers may consider carrying out the following actions to aid the health department with case investigation and contact tracing in the workplace setting. These include establishing a COVID-19 coordinator or team for the workplace, understanding the health department's response ahead of time, creating and implementing a preparedness response and control plan, collecting information in advance about the workplace operations, staffing, and infection control programs and practices that may be shared with the health department. Employers should always support employees in preparing for this, and conduct workplace hazard evaluation and prevention activities. And finally, provide information about the case investigation and contact tracing processes to employees. In conclusion, CDC encourages employers and employees to work closely with the health department if they are contacted, because time is of the essence for effective contact tracing to prevent COVID-19 transmission. And now I'd like to pass it over to Dr. Piacentino.
Great, thank you, Dr. Luckhaupt. My name is Dr. John Piacentino, and I'm the Associate Director for Science for the National Institute for Occupational Safety and Health. And today I'm pleased to share information on a new resource entitled SARS-CoV-2 Testing Strategy Considerations for Non-Healthcare Workplaces. The purpose of this document is to provide employers with strategies for consideration of incorporating testing for SARS-CoV-2, the virus that causes COVID-19, into a workplace COVID-19 preparedness response and control plan. These considerations are meant to supplement, not replace, any federal, state, local, territorial, or tribal health and safety laws, rules, and regulations with which workplaces must comply. For today's discussion, I will be focusing on viral tests. Viral tests approved or authorized by the Food and Drug Administration are used to diagnose current infection with SARS-CoV-2. Viral tests evaluate whether the virus is present in respiratory or other samples. This is different than antibody tests. Antibody tests approved or authorized by the FDA are used to detect past infection with SARS-CoV-2. I would like to start with some general considerations around incorporating testing, and more specifically, disclosures and information for employees. Employees undergoing testing should receive clear information on the manufacturer and the name of the test, the type of test, the purpose of the test, the reliability of the test, any limitations associated with the test, who will pay for the test, and how the test will be performed. Additionally, it's important for employees to receive clear information on how to understand what the test results mean, actions associated with negative or positive results, who will receive the results, how the results may be used, and any consequences for declining to be tested. CDC describes 5 categories of people for viral testing. These categories include testing individuals with signs or symptoms consistent with COVID-19, testing asymptomatic individuals, that is, individuals without signs or symptoms, and those asymptomatic with recent known or suspected exposure, testing asymptomatic individuals without known or suspected exposure to SARS-CoV-2 for early identification in special settings, testing to determine resolution of infection, and public health surveillance. I would like to mention a few considerations that are relevant to workplaces and take each of these categories of people in a little further detail. And so let's start with testing individuals with signs or symptoms consistent with COVID-19. In workplaces, workers with COVID-19 symptoms should be immediately separated from other employees, customers, and visitors and sent home, or to a healthcare facility, depending on how severe their symptoms are, and following CDC guidance for caring for oneself. It's important to prevent stigma and discrimination in the workplace, and so employers are advised to make employee health screening as private as possible. Some individuals may be referred for testing, and those referrals should be consistent with CDC recommendations for evaluation and potential testing. Additionally, it's important for employers to implement flexible sick leave and supportive policies and practices as part of a comprehensive approach to prevent and reduce transmission among employees. And so 2 notes: the Families First Coronavirus Response Act requires certain employers to provide their employees with paid sick leave or expanded family and medical leave for specified reasons related to COVID-19. And employers with fewer than 500 employees are eligible for 100% tax credits for Family First Coronavirus Response Act paid leave provided through December 31st, 2020, up to certain limits. All right, let's talk about testing to determine resolution of infection. And thank you to Dr. Brooks for reviewing with us prior changes to CDC recommendations. The decision to end home isolation and return to work for employees with suspected or confirmed COVID-19 should be made in the context of clinical and local circumstances. And as Dr. Brooks previously mentioned, PCR amplification tests have detected SARS-CoV-2 RNA in some people's respiratory samples after they have recovered from COVID-19. And prolonged viral shedding has been demonstrated without direct evidence for a replication-competent virus. Consequently, in most cases, a symptom-based strategy should be used to determine when to discontinue or end home isolation. Now, for persons who are severely immunocompromised, a test-based strategy could be considered, but as previously mentioned, in consultation with infectious disease experts. But for all others, a test-based strategy is no longer recommended, except to discontinue or end isolation earlier than would occur under the symptom-based strategy. Okay, I'd like to focus now on testing asymptomatic individuals. These are individuals without signs or symptoms. Asymptomatic individuals with recent known or suspected exposure to SARS-CoV-2. And as Dr. Luckhaupt mentioned, viral testing is recommended for all close contacts of persons with COVID-19. And additionally, employers are encouraged to work with public health departments investigating cases of COVID-19 and tracing contacts to help reduce the spread of SARS-CoV-2 in workplaces in the community. Another group of individuals that CDC has recommendations for includes testing asymptomatic individuals without known or suspected exposure to SARS-CoV-2, and this is for early identification in special settings. Viral testing of workers without symptoms may be useful to detect COVID-19 early and stop transmission, particularly in areas with moderate to substantial community transmission. Workplace settings for which these approaches may be considered include workplaces where physical distancing is difficult and workers are in close contact with coworkers or the public, workplaces in remote settings where medical evaluation or treatment may be delayed, workplaces where continuity of operations is a high priority, such as for critical infrastructure sectors, workplaces providing congregate housing for employees, and this would include fishing vessels, offshore oil platforms, farm worker housing, or wildland firefighter camps. However, employers are advised that before testing a large proportion of asymptomatic workers without known or suspected exposure, employers are encouraged to have a plan in place for how they will modify operations based on test results and manage a higher risk of false positive results in a low prevalence population. Lastly, I'd like to just make a comment about surveillance. Testing is considered to be surveillance when conducted to detect transmission hotspots or to better understand disease trends in the workplace. These goals are consistent with employer-based occupational medical surveillance programs. Occupational medicine surveillance programs may be use testing to assess the burden of SARS-CoV-2 in the workforce, assess factors that place employees at risk for workplace acquisition of SARS-CoV-2, or evaluate the effectiveness of workplace infection control programs. In summary, I'd just like to highlight the importance that if someone is considering SARS-CoV testing, that it be incorporated as part of a comprehensive approach to reduce transmission in non-healthcare workplaces, and just say thank you to everyone for your attention.
Great, thank you so much. And now it's my turn having issues getting off of mute. This is Erin again. Thank you so much to all of our experts for sharing these updates. The next part of our call is our question and answer section. We received some questions in advance, so thank you to all who were able to submit those. And we're going to start with a few of those. You're also welcome to continue to submit questions via the Q&A button in Zoom. So I'd like to start with one general question for Dr. Brooks. Can you explain to us how a city or a state's test positivity rate can be used as an indicator for when it's safe to reopen?
Yeah, sure. I'd be happy to answer that. So that we're all on the same page here, the positivity rate means among all of the tests that are conducted in a jurisdiction, what's the fraction or the percent of those tests that's positive? Ideally, we'd like to see that number below 1%, because in general, at least from an epidemiologic perspective, we consider something an epidemic when the fraction, and this is a general rule of thumb, and we'll adapt it if we need to, but in general, once you exceed 1% of people being tested having the condition, we start to worry a lot about it still being an epidemic. So we want to get that number as low as possible. The problem often arises, though, with how the testing is distributed. Sometimes you can get a really high positivity rate because the people who are being directed to testing might be those that are sickest. You know, when you start looking at a disease for the first time, the people who are evidently ill are the ones that you're most worried about. And that can artificially raise the positivity rate because most of the tests are being administered to people who clearly have the virus, and your chances of hitting a positive case are much increased compared to if you were more generalized. That's why it's so important for jurisdictions to cast a very wide net in terms of testing so that they are testing a large and representative sample of their community and the population. Testing is the best way to know how much the virus is spreading within communities, and that helps us make informed decisions about reopening. So I think what I'll just end with is that the positivity rate then is the most important way, or one of the most important ways for us to see how much spread is occurring and monitoring what's going on.
That's incredibly helpful. Thank you. This question is for Dr. Piacentino. Can you explain the different types of COVID-19 tests and when we should get tested?
Sure, thanks. Yeah, thanks for that. So as I think I previously mentioned, there are two kinds of tests available for COVID-19. There are viral tests and antibody tests. And so a viral test checks for current infection, and an antibody test checks for previous or past infection. If you think that you need a viral test, we recommend that you call your healthcare provider or state or local health department and tell them about your symptoms and how you think you may have been exposed to the virus. Your healthcare provider or health department can let you know if they offer viral tests at their office and provide local information on where testing may be available. If you want an antibody test, again, call your healthcare provider to see if they offer an antibody test and whether you should get one. You can also visit your state or local health department for local information on antibody testing. In terms of who should get tested, as I went through very quickly, the CDC has consolidated recommendations for COVID-19 testing. And these recommendations really center on the viral testing. This is the testing that's used to diagnose current infection for 5 groups. And so one group, and I'll just comment on 4. One group is those that have signs or symptoms of COVID-19. The next group would be folks that don't have symptoms but recently had contact with someone known or suspected to have COVID-19. Another group includes somebody that doesn't have symptoms, they've had no contact with someone, but they still need to be tested because early identification in a special setting would be important. An example of that would be in a correctional facility or a long-term care facility. And then the last group in terms of who is recommended for testing would be those who have had COVID-19 but no longer have symptoms. Some individuals in this group may be tested by public health officials to track spread of the virus that caused COVID-19. And just to note that we previously discussed revision to CDC recommendations for testing to determine discontinuation of isolation. If you have symptoms of COVID-19 and want to get tested, you can certainly call your healthcare provider first. And symptoms that of COVID-19 it's a variety of symptoms, but some include fever or chills, cough, shortness of breath or difficulty breathing, fatigue, muscle or body aches, headache, new loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting, and diarrhea. Thank you.
Thank you. Another question for Dr. Piacentino. Don't go anywhere. Should I be screening my employees for COVID-19 symptoms? And if so, what's the best way to do that? We've heard this from a few different people.
Yeah, sure. Thank you for that. So screening employees is an optional strategy that employers can use. And performing screening or health checks will not be completely effective because some folks are asymptomatic or they have mild or non-specific symptoms. Asymptomatic meaning I just don't have symptoms. And they may not realize that they're infected and may pass through screening. So screening and health checks are not a replacement for other protective measures such as social distancing. We advise that you consider encouraging individuals planning to enter the workplace to self-screen prior to coming on site and not attempt to enter the workplace if they have any of the following. And so if you have a fever, and that means higher than 100.4 degrees Fahrenheit. If you're under evaluation for COVID-19, so for example, you're waiting for a result of a viral test to confirm whether or not you have infection. If you've been diagnosed with COVID-19 and if you've not been cleared yet to return or to end isolation, those individuals really should not attempt to come into the workplace. And just to note that for the 100.4 degree Fahrenheit, a lower temperature of 100.0 could be used, especially in, say, healthcare settings. If you decide to actively screen employees for symptoms rather than relying on self-screening, then consider focusing the screening questions on new or unexpected symptoms so that chronic conditions wouldn't result in a positive screen. And if you will screen employees, then you should consider how you're going to protect the employees conducting the screening. The most protective methods include incorporating a form of social distancing, so maintaining a distance of 6 feet from others, using physical barriers to eliminate or minimize the screener's exposure due to close contact with a person. And if social distancing or barrier controls cannot be implemented, then personal protective equipment can be used when the screener is within 6 feet or of an employee during screening. However, reliance on PPE, personal protective equipment alone, is less effective and more difficult to implement given that given that there are shortages in personal protective equipment, as well as given training requirements around the use of personal protective equipment in workplaces. So I hope that answers the question on screening.
Yeah, that's very helpful. Thank you so much. And I believe our next question is best for Dr. Luckhaupt. What can be done to protect employees who can't maintain social distancing from other employees or from customers?
Okay, thank you for that question. That's one that we get a lot. And so we've just added some additional information about this to our general business frequently asked question page. But the first step is to evaluate your workplace to identify situations where employees cannot maintain a distance of at least 6 feet from each other and or the customers, and use appropriate combinations of controls following the hierarchy of controls to address these situations to limit the spread of virus. A committee of both employees and management may be the most effective way to recognize and figure out solutions for all of these scenarios. And it is important to note that control recommendations or interventions assigned to reduce the risk of spreading COVID-19 must also be compatible with any safety programs and personal protective equipment or PPE normally required for the job tasks. So the The next step is to alter the workspace using engineering controls to prevent exposure to the virus. And this might include making sure that the workspace is well ventilated. And there's a link to some information about ways that you might want to do this on the General Business FAQ page. You might also change the alignment of workstations where feasible. For example, redesign workstations so that employees are not facing each other. Then you can use visual cues such as floor decals, colored tape, and signs to remind employees to maintain that distance of 6 feet from others when possible. And this includes both at the workstations and in break areas and other common spaces. Also consider these cues for customers, such as at the entrance or checkout line. And then place hand washing stations or hand sanitizers with at least 60% alcohol throughout the workplace for employees and customers. It's also important to provide training and other administrative policies to prevent the spread of COVID-19. And as we have mentioned before, it's really important to recommend that employees wear a cloth face covering. Now, cloth face covering should not be worn if their use creates a new risk, such as interfering with driving or vision or contributing to heat-related illness that exceeds their benefit in slowing the spread of the virus. But in most cases, there can be a way to implement them. And recommend that visitors to the workplace, including service personnel and customers, also wear cloth face coverings. And PPE, or personal protective equipment, is the last step in the hierarchy of controls because it is harder to use effectively than other measures. And to be protective and not introduce an additional hazard, the use of PPE requires characterization of the environment, knowledge of the hazard, training, and consistent correct use. This is why administrative and engineering controls are emphasized in guidance to slow the spread of COVID-19. In the current pandemic, use of PPE such as surgical masks or N95 respirators is being prioritized for healthcare employees and other medical first responders, as recommended by current CDC guidance, unless they were required for the job before the pandemic.
All right, thank you so much. I have one follow-up to that question for Dr. Luckhaupt. Should we require that face coverings be worn in an office environment that holds multiple employees, even when they are seated with a minimum separation of 6 feet in any direction?
Yes, thanks. So that goes back to that first step of evaluating the work environment for situations when social distancing is most difficult. So if employees are seated at least 6 feet away from others and are staying in their seats, they may not need to wear cloth face coverings while they're at their desks. But it is still important to wear a cloth face covering when employees are moving around in the office, such as in a hallway or break room or other common areas.
Thank you so much. Let's see, I have one question for Dr. Brooks. And I've heard this from a couple different people that goes along with what Dr. Luckhaupt was talking about. How can I protect my employees who are at a higher risk of severe illness from COVID-19?
That's a good question because, I mean, many of us supervise folks and we want to make sure that they're well taken care of. So you probably have heard that travel should be minimized as much as possible during the pandemic. We also recognize that many jobs require people to travel, and so it may not be possible to conduct certain job duties using virtual tools. And in those kinds of situations, let me kind of go through what we would recommend to protect employees while traveling. First, schedule the travel to limit the distance the person needs to travel, as well as the need for overnight lodging. That helps reduce the opportunity for exposure to COVID. And if multi-day travel is needed, coordinate that with the travel preparer to identify hotels that you know are disinfecting rooms between stays and regularly disinfect surfaces in common areas. And don't be afraid to try to look it up online or call them direct to get a straight answer. Provide employees with forms of transportation that minimize contact with others, such as fleet vehicles or rental vehicles. And if public transportation is used, make sure your employees know how to and follow CDC's guidance on how to protect yourself when using such transportation. Flying has been a part of our normal lives for a long time, and it's necessary in many cases, and in that circumstance, select a seat on a flight that provides the greatest distance between other travelers as possible. And I recognize that's not always under travelers' control, but to the extent it can be, do your best. Also, choose a direct flight. Always goes better than having to transfer. If you're using a rental car or a fleet vehicle, make sure you disinfect the frequently touched surfaces like the steering wheel, the shifter arm, armrests between each use, and use products that meet EPA's criteria for use against SARS-CoV-2. They've got a special icon on them so you can recognize them. And then for people who are traveling, make sure your travelers provided the necessary supplies and understands protective measures he or she can take while they're traveling. And these include, as we've said many times, I think so far today, maintain that 6-foot distance, keep up your social distancing as much as you can during travel, wear a cloth face covering when a distance of 6 feet is difficult to maintain, such as in an airport, an airplane, or in public transportation. Use disinfecting wipes to clean those commonly touched surfaces inside vehicles, inside of airplanes, and even in the hotel room if you're worried about that. No reason you can't go through again. Consider when you order food, having it delivered or ordered for pickup rather than going out to a restaurant to get it. You're going to be in a higher risk of encountering the virus, and that's why it's important to wash your hands regularly and as recommended for 20 minutes using soap and water or with a hand sanitizer. Now, I do want to point out that there are a lot of hand sanitizers out there. CDC recommends that it have at least 60% alcohol, but there are different kinds of alcohol. And we've learned that, unfortunately, some products being distributed in the United States contain a kind of alcohol called methanol, methanol, methanol. And although this is can be sterilizing, it's also very dangerous. And we want people to avoid using a product that contains methanol. Too much exposure can lead to substantial absorption of methanol through the skin, and this can lead to illness, including irreversible blindness. So check the product to make sure it does not contain methanol. Lastly, ensure that your employees know what to do if they get sick. Who should they call? When should they stay at home? When should they not travel? Or how should they return home or shelter in place where they're located in case they do get ill? Who can they call to get some advice at your end? So make sure employees know who to contact if they feel sick or develop symptoms of COVID. Turn it back over to our moderator.
I was going to say, we were looking at a question, and I think you did just answer this around the recent FDA health alert regarding the use of sanitizer with methanol, but I think that you just gave us that information.
Yeah, let's avoid the methanol, please. It's bad when it happens. Yep.
Appreciate that. I do have one question for you that it came in ahead of time and on the Q&A. This is again for Dr. Brooks. Why are hospitals now told not to send data to CDC, and how will this impact CDC's COVID-19 response?
Yeah, hold on, let me make sure I am off mute. There I am. Yeah, I think I'm off mute.
Yeah,
sorry about that. I'm sometimes flipping back and forth because I don't want to interrupt other folks who are taking their time to talk to us. Well, listen, yeah, I know this has been in the news an awful lot just recently, and it's a subject of a lot of discussion. So let me tell you some of the things that we can share today with what we know is going on here. I mean, obviously, data is fundamental to public health. Data helps us understand the impact of COVID-19 on the capacity of our U.S. healthcare system, and that includes both hospitals as well as long-term care facilities like nursing homes. HHS Protect, that's the name of the platform for sharing healthcare information so that the US government can harness the full power of data for the COVID-19 response. And I'll just remind people that this has been operational since April 10th, 2020. With HHS Protect, more than 200 data sources are being brought together into one ecosystem that provides a holistic view of our healthcare system, and that allows decision makers the information they need to make real-time or near real-time decisions to guide action and save lives with our data-driven COVID-19 response. Point here is that CDC's existing National Healthcare Safety Network, or what's called the NHSN, is going to continue collecting COVID-19 data from nursing homes and long-term care facilities. NHSN will also continue its efforts around data collection from hospitals across the US to fight against antibiotic resistance, and the NHSN hospital data through July 15th, 2020 will continue to be available on cdc.gov. Hospitals will begin reporting COVID-19 data directly, however, to HHS through teletracking or to state health departments or state hospital associations, which then shares data with HHS via HHS Protect. And I just want to reassure folks that CDC staff will continue to have access to HHS Protect for analyses as needed.
All right, thank you for addressing that. I know this will jump just a little bit, but I want to go back to Dr. Luckhaupt. How can an employer balance helping a health department with contact tracing of employees, which requires asking about protected health information in some cases, and still be compliant under Hipaa?
Yeah, so that's a question that we get a lot. And one of the reasons that we wanted to put out this new guidance about how employers can work with health departments on contact tracing. So the first thing to remember is that we're not asking employers to do all of the things that health departments do when it comes to case investigation and contact tracing. But really, we want the employer to help mostly by providing information about the workplace that would help the health department determine which workers were most likely to have close contact with someone who has been identified as a COVID-19 case. So not necessarily for the employer to try to identify which workers are at the highest risk of severe disease, which is when you need to get into pre-existing conditions, but just
Oh no.
understand aspects of the workplace. Useful things an employer may choose to do is to prepare and quickly provide information and records to the health department about the workplace, potential workplace contacts, and when needed workplace operations without revealing confidential personnel records or confidential business information. And note that all of the activities and information collected by an employer should be limited to the work setting and be consistent with applicable local, state, and federal privacy, health, medical, and workplace laws and regulations. So there's some more information about that in the guidance.
Thank you, Sarah, for that. Very helpful. We have another one from the Q&A box. For ending isolation in asymptomatic positive patients, is it 10 days from when the test was collected or 10 days from when results are received? Sometimes it can be a week or more before test results are received. This one we'll send to Dr. Brooks.
Yeah, I know that frustration of waiting to get your test back.
Yep.
Yeah, I've had the same problem personally. So question here, it's from the date of collection. All right, we want to know about the time when the specimen was collected. That will give us the best chance of really isolating the person during the period where we think they're most infectious. You could start if you wanted at 10 days when the result comes back, but if you collected but that specimen was collected 10 days ago, we should have given the person that benefit to start counting from back then, because as people recover from this infection, and I haven't mentioned this yet, but just remember this, as people recover from infection, although they're most infectious just before and just shortly after they develop infection, the amount of virus that we can detect and the amount of viral particles that we can detect in their respiratory secretion steadily goes down. So the farther out you are, we believe the closer you are to full recovery and the less infectious you become. I also want to clarify something, because I know this is a point of constant confusion, and it confuses me too, because it's a little weird. We're talking right now about discontinuing isolation for people diagnosed with COVID-19, and that's 10 days. People keep asking me, well, what about 14 days? I just want to remind people that 14 days is the amount of time that we recommend a person be quarantined after they have been exposed to a case of COVID, but they are not known to be infected. If they're tested and found to be infected as part of a contact tracing investigation, let's say, then they need to isolate for 10 days. Now, why is it, and this seems strange, I know, why is it the quarantine period is longer than the isolation period? It's because the time it takes to recover from the virus, 10 days, is shorter than the incubation period of the infection. And I won't go into it now, but that's part of the reason why some people can transmit before they're evidently ill. So we need the person who has been exposed but not yet known to infection to quarantine for full 14 days, the full time over which they might develop and express an infection. And it can be up at day 13, hour 10, or 11, or 12. You know, we just, unfortunately, that's you got to wait to that 99.9% point to really be assured.
Yeah, and I know that can be difficult. Okay, I want to get through two more questions if we can, because I know a lot of this is incredibly important for people. One that came in ahead of time, and also I saw in the chat, or the Q&A box, I'm sorry. Dr. Brooks, can you address the latest concerns by scientists that say COVID-19 is airborne?
Happy to. This concerns us too. I think sometimes people think we don't care about it because all they do is hear us talking about the 6-foot zone and respiratory droplets and particles. But you know, what comes out of our mouths is a broad spectrum of particles of many sizes. The big goobers that you sometimes unfortunately watch land on somebody, and then all those little tiny particles down to these micron, 5 micron and less size, which are called aerosol-sized droplets. We have experimental data from our agency, and there are other places that show that these little particles, these tiny aerosol-sized particles, can float in the air for a long time, and that if you spike them with a virus, you can recover virus from them for a couple of hours afterwards. Let me just note that that doesn't mean that I can recover the same amount of virus from them over that period of time. We know that the amount of virus that's alive and potentially infectious is going down in those particles. But in those perfect experimental conditions where the temperature, the humidity are all nicely controlled, and there's no air movement, right? We can make this happen. Well, that's the ideal circumstance. What do we observe, though, as epidemiologists in the real world? And what I'm talking about here is what is the difference? And real world may be a little too strong, but what I'm trying to communicate is what is the difference between what I see in a perfect laboratory experiment and what I actually see in terms of how transmissions are occurring. We haven't seen a signature of transmission consistent with what is commonly called airborne transmission. So transmission where airborne particles can carry an infection and really cause a lot of illness. 2 examples where that is a problem are measles and tuberculosis. And as an example of what you might expect to see if this were being transmitted like measles and tuberculosis. If this were measles, I might expect that there had been people in a large room together, very far apart, but had never come in direct contact with one another, and certainly a lot wider than 6 feet, and yet you could document a transmission occurred. Or I could have had a situation where a person who has infection passes through a small area, and then other people follow that person and become infected. That's been observed with measles for sure. And what is an example of where that might have occurred? Well, consider elevators. You know, there have been 14 million infections now worldwide, okay? It's a lot of opportunity. And we have examples where people have shared elevators or bathrooms or other spaces and moved in and out, but not been there at the same time, and we don't see transmission in those circumstances. And if folks want, I can go into more detail, but the last one I want to highlight is air handling systems. If this virus were really efficiently transmitted as an airborne pathogen, you might expect to see what we've seen with tuberculosis, where a person in one room can cough or breathe, and the air intake system picks that up and then carries it down the hallway and deposits it in another person's office, even though the 2 people are physically separated. And we haven't seen that either. What we have seen are some pretty remarkable stories where you get the perfect circumstances aligning. If all the stars align just right, there probably are circumstances where you can make it happen, okay? If you put, these are real examples, if you put 2 people in a squash court and close the door, it has no ventilation, and you have them play a squash game for 50 minutes and then walk out and there's no ventilation, the next pair of people who walk in there, if one of the ones in the first pair was ill, could get infected, and we've seen that happen. Or if you put a choir together in a closed room with poor ventilation and you have them really sing, and I don't know how many of you are singers, but you are pumping your diaphragm really hard, and that's a lot of stuff coming out of your mouth. Sure, you could build it up or concentrate it. Or there's a case of an aerobic studio, actually it was a Zumba studio for aficionados in Seoul, where a woman who just before she knew she was infected was teaching a class, and it was a closed room with 20 women kicking rear end. They're really putting it on for 50 minutes, and Daggett transmitted to people at the far side of the room. So sure, under those circumstances, it can happen, but it isn't the main way we're seeing infection. Most infections are occurring in those close encounters, crowding in a bar, talking to someone for a prolonged period next to them. Regardless, we are concerned about the possibility that this could have a component of airborne transmission, and our guidance reflects that. Our guidance contains lots of information about how to increase ventilation. And here I go back to the 1960s when I was sort of in the hippie years, and we would say, dilution is the solution to pollution. The more fresh air you can get into a place, the sooner you don't have to worry about what's been deposited there. So air handling systems boost the air exchange is to the maximum. Increase that air handling system pulling in of outside air and conditioning it for indoor use. If you can put a filter in there, do it. Highest MERV setting or a HEPA filter. If you can't, think about cracking a door, opening a window, installing fans. All of these things can keep the air moving so that even if there is something in the air, there's not enough to infect someone.
That is incredibly helpful for me. I'm sure it is for others too. And I know that we're at 4 o'clock, but I do think that this last one is incredibly important because we're thinking about going back into workplace settings. Dr. Luckhaupt, would you please help us understand how do you envision the office environment would look like in our new normal? What would you envision the office of the future to look like for us?
Yeah, sure. So it's really important to acknowledge that as this virus is going to be around for a while, that as we go back into the offices, they're not going to look quite the same. So some of the things that you might want to see and expect to see are that there's a modification or adjustment of seats, furniture, and workstations to maintain that minimum social distancing of 6 feet between employees. In some cases, they'll be installing transparent shields or other physical barriers where possible to separate employees and visitors where social distancing is not an option. Arrange reception or other communal seating area chairs by turning or draping, such as covering the chair with tape or fabric so seats cannot be used, spacing or removing chairs to maintain social distancing, because we all need those reminders of the importance of this, and using methods to physically separate employees in all areas of the facilities, including work areas and other areas such as meeting rooms, break rooms, parking lots, entrance and exit areas, and locker rooms. Many employers will use signs, tape marks, or other visual cues, such as colored tape on the floor, placed at least 6 feet apart to indicate where to stand when physical barriers are not possible. Replace high-touch communal items such as coffee pots and bulk snacks with alternatives such as prepackaged single-serving items. We may see staggering of shifts, start times, and break times as feasible to reduce the density of employees in common areas. And while the weather is nice, hopefully we'll be able to move some activities outdoors, such as meetings, breaks, or lunches when appropriate. So these are just some of the things that we suggest to employers and that we tell employees you may expect as we go back into the office.
Thank you so much for that. I think that concrete examples are really helpful for all of us to be able to visualize what we can do as employers and what we can expect as employees. So this concludes our time together. Thank you so much to all of our experts. I know that I'm now smarter for having listened to all of this. Dr. Brooks, Dr. Luckhaupt, Dr. Piacentino. Do you have any additional closing remarks or additional thoughts to share with our audience?
I just want to reiterate how grateful we are that folks are taking the time to join us and offer, one, really great questions, and to learn about what's going on, because I think misinformation is one of our greatest enemies in public health right now. And there's a lot of rumors, a lot of strange thoughts out there. And the more that we can help you know what we believe the best available science is telling us, the more you can help us ensure that people get the best available science to make the right decisions for their health.
Agreed. Thank you for that. And thank you to everyone for joining our call today and taking the time to do so. A recording will be posted online on CDC's COVID-19 webpage. And again, the subscription link to receive future updates and invitations is listed at the top of the chat box. So please find that if you haven't already. Thank you again, and please join us next week. Bye from all of us.